According to the American Heart Association, which our speaker is just the past president of, at least 80% of strokes are preventable. So since Atria really is all about preventing complex disease and disease prevention, this is an especially important topic. So I couldn't be happier today to have with us one of our Academy Fellows and a renowned stroke expert, Dr. Mitchell Elkind. Dr. Elkind is a tenured professor of neurology and epidemiology at Columbia University. And since September, just a little more than 2 months ago, he's now the Chief Clinical Science Officer of the American Heart Association. He was previously Chief of the Division of Neurology, Clinical Outcomes Research, and Population Sciences, or NeuroCorps, in the Neurology Department at Columbia. For many years, I've been reading Dr. Elkind's work. He has had a tremendous impact on patient care, a tremendous impact on the New York stroke community as a director of NOMAS, which is a renowned epidemiology and public health effort that was started back, probably more than 30 years ago now. And he's had a tremendous impact on public health, both through his academic career and in his tenure as president of the American Heart Association. I was reading his presidential address from last year. He was president during COVID, and the public health efforts that he led at one of the most chaotic times in our history is just remarkable. And he said in that presidential address, which I read word for word, one of the quotes that caught me was, listening done properly is a highly active and satisfying process. So we're going to be listening to you today, Dr. Elkind. His research spans a variety of different areas, including stroke prevention, inflammatory and infectious biomarkers, in stroke risk prediction, atrial cardiopathy, which is a relatively novel, I think, even for vascular neurologists concept, immune therapy for acute stroke, and vascular causes of cognitive aging. He's the principal investigator of several independent investigator awards from the NIH and NINDS, including a really important trial that's ongoing right now called the Arcadia trial, looking at apixaban versus aspirin for atrial cardiopathy in cryptogenic stroke. So Dr. Elkind, thank you so much for being here today. Thank you for making the time, and we look forward to your presentation.
Well, thank you so much, David, for that really warm and generous introduction. Really appreciate it. And it's great to be here this evening with the Atria community to talk about stroke. And I thought I'd actually start out with a little bit of history, both neurological and personal as well. So as David mentioned, I've been on faculty at Columbia University in the stroke division and in the Department of Epidemiology for 25 years. And just a couple of months ago, I became the Chief Clinical Science Officer of the American Heart Association. And some of you may be wondering, why would a neurologist serve as president of the Heart Association and now be working full-time for the Heart Association? And the reason is that the American Heart Association isn't really like several other professional organizations like the American College of Cardiology or the American Academy of Neurology. It's not a group focused on physicians. It's really a public health organization. It's focused on improving the health of all people, cardiovascular health, and potentially other aspects of health as well. You know, the Heart Association was initially founded in 1924. And so we're approaching in 2024, the 100th anniversary of the Heart Association. And we're beginning to vision what we're going to do for the next century. Certainly, we've been interested in stroke for a long time. And about 25 years ago, the American Stroke Association was founded as a division of the Heart Association. But now, we've begun to recognize that brain health and neuroscience are going to become an increasingly important part of the future of the work of the Heart Association. So I recognize that I could have a much greater impact on the future of brain health, stroke, dementia, all these different aspects of clinical neuroscience by moving myself to the American Heart Association for my academic position. Although, of course, I plan to continue working with my colleagues in academia at Columbia and really across the country as well. Here are some of my disclosures, a couple of them relevant to what I'll talk about in a little while, the support for the Arcadia trial from BMS Pfizer and Roche Diagnostics as well. And let me tell you a little bit along the lines of personal history as well. What got me interested in neurology in the first place? You know, why study the brain? Why would anybody want to study the brain? We got lots of organs in the body. We got, you know, the heart, we got the lungs. They're all important and we can't survive without them. The brain is a relatively small organ, weighs only about 3 pounds, so less than, you know, the average thigh, let's say. It's got a lot of stuff going on, incredibly complex. And, you know, as Hippocrates recognized thousands of years ago, it is the seat of all of what makes us human, really. It's the seat of all our intelligence, all our mistakes, peace, madness, creativity, art, etc. And so that's what fascinated me, and I think most people who go into neurology about the brain, is trying to understand that complexity and understand really the mystery of what makes the brain so interesting. Now, as a clinical neurologist, as opposed to a fundamental neuroscientist, I learn about these issues of what happens in the mind and the brain, primarily through brain injury. And that's been the long tradition through the history of neuroscience. So we learn about how the brain works by looking at people who've had strokes, for example, or other types of brain injury. And here's an example of a stroke, a large infarct in the left hemisphere. And you can see that it's caused by a blood clot, occluding a vessel going to the brain, one of the large blood vessels. There are also strokes in the deep blood vessels of the brain, and we'll return to an example of that a little bit later. Strokes, of course, can cause a myriad of different symptoms, depending on what part of the body is affected. Early or in the mid-19th century, investigators and clinicians began to appreciate that damage to particular parts of the brain could lead to specific neurological deficits. In this case, Charles Broca recognized that injury to the left side of the brain, the left frontal lobe, could lead to the loss of the ability to speak, for example. And this changed the way people thought about the brain, because before that, people thought of the brain as a kind of holistic organ, and functions could be spread throughout the brain, kind of like chocolate through a marble cake or something like that. But the work of Broca and others showed that these functions are specifically located in particular parts of the brain. And even within some functions, like language, for example, there are different aspects of language that can be affected by stroke in one place versus another. So whether it's the ability to produce speech, understand speech, repeat speech, read, write, name, and so forth, those were all spread throughout the body. And this was just absolutely fascinating to me. And it's also relevant, right? If you think about the recent election in the Senate election in Pennsylvania between John Fetterman and my old Columbia colleague, Mehmet Oz, there was a lot of questions about what was the meaning of having a stroke to somebody's ability to function normally. And what we saw there was that despite having a stroke, the word stroke doesn't tell you in great enough detail what might be wrong with somebody. There are many different aspects of function that could be affected, and it all depends on what part of the brain is involved. Now, some of you may recognize this friendly-looking fellow from medical school. Before there was a movie called The Homunculus, there was the Homunculus, who indicates and kind of fills out that idea of localization within the brain. Specific parts of the brain carry information for particular parts of the body, and the size of that part of the body is indicated by the size of the representation in the brain. So parts of the brain that control hand function and facial expression, for example, get a lot more real estate in the brain. And that's because we need that territory in order to be able to play piano, use chopsticks, things like that. Places like the hips and the shoulders get a lot less territory devoted to them. The other thing that I love about neurology is the neurological exam. And even though we have lots of fancy tests, MRI scans, and so forth these days, it really for us always comes back to the history. That's the listening that David just mentioned. Thank you, David, for calling that out. And also the neurological exam. And here's one of the great practitioners of the neurological exam at the Salpêtrière over 100 years ago with all of his students. This is Jean-Marie Charcot in Paris, performing an exam with many of his students who went on to become leaders in neurology and clinical neuroscience as well. And here's the man who I think many people would say is probably the most famous neurologist of all time, and that's Oliver Sacks, who wrote many books that really brought neurology into the popular canon. Many of them went on to become movies as well, teaching the general public about the importance of neurology and really how the brain works. And what was so wonderful about the writing of Oliver is that he really expressed that mystery that captures the essence of neurology and the way in which the brain functions, the idea that there's so much more that we have to learn. And he did it with tremendous humanity and humanism and beauty in his writing as well. And so with that kind of framing of mystery, that's why I want to talk today about this topic of cryptogenic stroke, which refers to a stroke which remains mysterious. We don't understand what caused the stroke. And here's an example of it. This is an MRI scan from a patient who presented with left arm and hand weakness and numbness, lasted just a short period of time. And you can see in the right side of his brain, in the part of the brain that controls just the hand, that bright white spot on diffusion weighted imaging, very sensitive to ischemia, is a tiny little infarct. And J.P. Moore at Columbia, who was one of my mentors, was the person who coined this idea of unexplained stroke. This patient had a thorough evaluation with no evident cause of their stroke found. And before we get into cryptogenic stroke in detail, just to say a few words about the epidemiology of stroke in general. Here you can see the course of stroke over the last decade or couple of decades, really, indicating that in blue, that the numbers of stroke declined over the first half of that decade or so, from 2007. But in recent years, the incidence of stroke and stroke mortality have actually been leveling off and actually increasing a little bit. So although overall we've done pretty well in the last 20, 30 years, stroke numbers going down, we've lost ground recently, and particularly in certain race ethnic groups. So among Black people, the risk of stroke is about twice as high as among white people. Hispanic population, it's intermediate between white and Black population. So even though the stroke rates have gone down overall in everyone, the rates or the disparities between whites and Blacks, for example, have persisted. They haven't dropped off as much in the Black population. And so we still have work to do to overcome that problem. And here you can see a map of stroke in the United States. This is actually stroke death rates from 5 years or so ago. And you can see that stroke is not homogeneously spread throughout the US. There's certain parts of the country that have a greater burden of stroke than others, particularly what we call the stroke belt in the southeastern United States. A number of reasons for that may be the cause, and still an area of active investigation as to why. But there are certain parts of the country that haven't seen those benefits either. And if we look globally at stroke mortality rates, we see the same kind of phenomenon where stroke rates are much higher in East Asia, in China, and other countries in Asia, as well as in Africa, interestingly. And so although we tend to think of stroke as being kind of a first world problem, if you will, other parts of the world are actually disproportionately affected by it. So again, we need to do a better job, and the Heart Association increasingly is working on global issues as well. So let's kick back to cryptogenic stroke again. In the Northern Manhattan study, thank you, David, for calling that out as well, about a third of strokes turned out to be cryptogenic. And this was work that was done by another one of my mentors, Ralph Sacco, who started the Northern Manhattan study back in the early 1990s. And you could see that we do an evaluation in stroke patients, looking at their heart, looking at their blood vessels, and about 20% of strokes have a definite cardioembolic cause. About 20% are due to atherosclerosis. Another 20 to 30% are due to small vessel disease that causes lacunar strokes. But even after a thorough evaluation, about a third of strokes are of unknown etiology. And here's a definition for cryptogenic stroke or ischemic stroke of undetermined origin. It's an infarct that can't be attributed to a definite source of large vessel atherosclerosis, cardiac embolism, or small vessel disease in the presence of a full cardiac and blood vessel and hematologic evaluation. An incomplete evaluation, we'll come back to that, or evidence of more than one competing cause. In other words, if somebody has a definite cardiac source like atrial fibrillation, but they also have carotid disease, then you don't know what caused the stroke. So they would have been labeled cryptogenic or unknown cause. So as I say, we do an evaluation on all stroke patients. We're looking at the carotid arteries to look for stenosis, as shown here. We look for definite sources of cardiac embolism listed here, primary among them atrial fibrillation, but also a clot in the heart, a recent heart attack, cardiomyopathy where the ejection fraction is markedly decreased, valvular disease, even tumors in some cases. Here's an example of an echocardiogram showing a big mass sitting within the left atrium, which is due to a left atrial myxoma. Now, it's important to remember that unexplained strokes don't just mean small strokes. Cryptogenic strokes are not defined by their size alone. Here's an infarct. This is an MRI scan of a 48-year-old African-American woman who had a history of untreated hypertension and came in with rapidly progressive right-sided weakness. And you can see this tiny little infarct deep in the left side of her brain. But notice that that stroke is not any different in size than the one I showed you in the gentleman from before. They're both small strokes. We consider the one on the left, in the 57-year-old man, to be an unexplained stroke that looks like an embolism that came from someplace else, whereas the lacunar infarct is due to a blockage in these very tiny vessels deep within the brain, generally due to high blood pressure or high cholesterol levels or diabetes, causing microatheroma or a thickening of those tiny little vessel walls leading to that little infarct deep within the brain. So that is not an example of cryptogenic stroke. This would be what a neurologist would call lacunar infarction or small vessel disease. We think of cryptogenic strokes as being characterized by their location. So here, again, showing you those small vessels with the deep stroke, superficial vessel, consistent with an embolism to the surface of the brain. In some cases, we get deep and superficial infarcts when an embolism blocks off, let's say, the territory here, right in the middle cerebral artery stem. It knocks out those little vessels, giving you a deep component as well as a superficial infarct at the same time. So that's a combination of those two locations. Now, if we go back to that original definition of unexplained stroke, you can see that that second item is an incomplete evaluation. Well, that's really dissatisfying, right? Because if somebody doesn't have a full evaluation, then of course we're not going to know what the cause of the stroke is. So this definition has largely fallen by the wayside. And now in the field, we tend to use this term embolic stroke of undetermined source. It looks like an embolism that came from, let's say, the heart, but we don't have a definite source in the heart or elsewhere. And so now we require a full evaluation, including the brain imaging, demonstration of absence of extracranial stenosis in the carotid artery, as well as intracranial stenosis in a vessel inside the brain, and no major risk cardioembolic source, like the things that I showed you just before, atrial fibrillation, significant valvular disease, and so forth. And so far, by definition, that's based on echo and at least 24 hours of cardiac monitoring, but we'll talk about this in a moment. And there's no other specific unusual cause of the stroke, like a dissection from trauma or something else, no evidence of vasculitis, and so forth. The other thing that I like to remind people when we think about stroke in general, and certainly unexplained stroke, is that at least when I'm evaluating a stroke patient, I'm thinking along two tracks at the same time. I want to understand what was the cause of their stroke to the best we can determine that. So that's why we do this evaluation. And we're also looking for potential risk factors. But we're doing those both at the same time. So if somebody comes in with a stroke and they happen to have, let's say, diabetes or smoke, we don't say, oh, we know what the cause of your stroke was. You smoke. You got to quit smoking. You won't have strokes anymore. Of course not. We do the full evaluation, heart, blood vessels, et cetera. And we also count up their risk factors, right? We're checking their blood pressure. We're checking their lipid levels. We're checking them for diabetes or glucose disorders, and we're managing those risk factors. And as we continue to try to prevent stroke in those patients, we're going to manage these things at the same time. They may need surgery. They may need an anticoagulant for their heart. But we're also addressing their risk factors too. Now, this idea that these unexplained strokes come from emboli from the heart is largely based on circumstantial evidence. I don't think I turned that off. Something just happened. There we go. And some of the more direct evidence from this, though, comes from very interesting studies that have been done recently. Now that we have the ability to do clot extraction, thrombectomy in patients with stroke, and we can look at the clots that are removed in the midst of an acute stroke and look at them under the microscope. And when investigators have done this, they have characterized, and this was work from a German group, and they characterize those clots along three axes that you can see in these triangles here. Their red cell content, their platelet content, and their white blood cell content. And interestingly, the clots that are removed from people with a definite cardioembolic source, like atrial fibrillation, are very similar in their cellular makeup to clots that come from people with cryptogenic stroke, suggesting, again, that those unexplained strokes are probably emboli coming from the heart. So there's indirect, but let's say pathological evidence for that concept. In terms of prevention in people who've had unexplained strokes, there have now been two large randomized trials, the Navigate ESUS trial and the Respect ESUS trial, that looked at people with unexplained stroke and randomized them to anticoagulants, the direct-acting oral anticoagulants. Navigate ESUS was rivaroxaban, Respect ESUS using dabigatran, thousands of patients, large-scale clinical trials. Neither one of them showed evidence of a benefit to using an anticoagulant compared with just aspirin in these patients. So at least right now, among patients with stroke of unexplained cause, even if it looks like an embolism, we don't have any definite evidence to use an anticoagulant. And that's probably reflective of the fact that these cryptogenic strokes are actually a heterogeneous group. We think of them as being one category, but there are probably many different causes within that group, some of which may respond better to anticoagulants and others may respond better to antiplatelet therapy. So for example, people with occult atrial fibrillation or occult cancer may do better with an anticoagulant, and people with atherosclerotic disease may do better with an antiplatelet agent. Now, here's a quote. We just got over, the election here in the United States, made me think back to previous elections and political times. And some of you may recognize Don Rumsfeld from the Bush administration, who was made fun of quite a bit, but he did say one thing that a lot of people recognize as being pretty wise. He said, there are known knowns. These are things we know that we know. There are known unknowns, right? That is to say, there are things that we know we don't know, but there are also unknown unknowns. These are things we don't know we don't know. A bit like a Zen koan, perhaps, but it does apply, believe it or not, to cryptogenic stroke. So somebody comes in with atrial fibrillation, that would be a known cause of stroke. We know how to treat that. Here's a long list of things that are potential causes of embolic stroke of undetermined source, what we might call the known unknowns. And we're not going to go into all these in detail. And then there are unknown unknowns as well. Those may be things we don't know about at all yet, or they may be things we just learned about, right? Like the possibility that things like COVID can cause stroke. So the two things that I want to focus on today, because these are areas that I've been most actively involved in researching, are what we call atrial cardiopathy and the role of infection in causing strokes. So if we think about atrial disease, we can go back decades into the 70s to think about how atrial fibrillation is related to risk of stroke. And one of the earliest people to recognize this association was C. Miller Fisher at Massachusetts General Hospital, who was in his 80s when I was a resident there and was still, rounding with us. And I feel very fortunate that I had the opportunity to work with him back then. Over the ensuing decade or so, there were trials that demonstrated that warfarin was better than aspirin in preventing stroke in people with atrial fibrillation. Into the 2000s, we began to recognize that paroxysmal atrial fibrillation, AF that comes and goes, can be a source of stroke as well. And of course, more recently, we've had the newer oral anticoagulants that have largely replaced warfarin for stroke prevention and further ways of risk stratifying patients with AFib. Now, if you talk to a cardiologist, and I have cardiologists sitting here with me today, they'll give me a long list of subtypes of atrial fibrillation. But I would say that from a neurologist perspective, the most important type of atrial fibrillation is what we call occult atrial fibrillation that doesn't get detected during their hospitalization, and the patient doesn't have a history of it before. And that's because these episodes can be very brief and hard to detect unless somebody's looking for them. Why does it matter? Well, it matters because anticoagulation is so effective at preventing recurrent stroke in people with atrial fibrillation. And in fact, it's the only common stroke mechanism for which anticoagulation has been shown to be of benefit. And yet it can be very hard to find it. AF can be paroxysmal, it can come and go. About a quarter of patients with AF first present with their atrial fibrillation when they have a stroke, right? So they don't have symptoms beforehand. Whether people have palpitations or not is a very poor indicator of the presence of atrial fibrillation. And even those who do turn out to have AFib, the AF burden may be very low, 1 to 2 hours a day, and present on less than 1 in 10 days overall. So very hard to find it. And that's why in many instances we do prolonged cardiac monitoring looking for atrial fibrillation in these patients. And there have been a couple of trials that have looked at the benefits of doing long-term monitoring in patients with an unexplained stroke. One was called the Embrace trial. This was a study conducted in Canada that looked at about 570 patients with cryptogenic stroke, or TIA, some point in the last 6 months. They had to be over age 55. And only 8% of them had a transesophageal echo looking for a source of clot in the heart. They'd had all the other potential causes of stroke excluded, and they were randomly assigned to just 24 hours of monitoring or to a 30-day event-triggered monitor. And the primary outcome in the study was not recurrent stroke, it was detection of atrial fibrillation by 90 days using 30 seconds of AF as the threshold. And what they found, perhaps not surprisingly, was that those who had a 30-day monitor were much more likely to have AF detected. For that AF of greater than 30 seconds at 90 days, 16% had that with the monitor implanted versus only 3.2% in the control group. And AF looked at in other ways similarly showed a much higher likelihood of detecting AF using the monitor. And it also led to a change in therapy so that patients who were found to have AF were more likely to go onto an anticoagulant. The next big study was the Crystal AF study. And this was a study among 440 cryptogenic stroke patients. In this case, patients were younger, over age 40. So their mean age was 61 compared with 73 in the EMBRACE trial. And in this case, all patients underwent a transesophageal echo. So this might have been a more selected group of patients in some ways, because anybody who did have a clot on TEE would not have gotten into the trial. So it was a different patient population. And in this case, they compared standard monitoring, 24 hours, to an implanted cardiac monitor. At the time, the Reveal XT device that had a lifetime of up to 3 years. And the primary endpoint here was similar, 30 seconds of AF by 6 months, although the monitor could stay in for up to 3 years. And again, there was evidence that having an implanted monitor was much more likely to turn up atrial fibrillation than just doing the 24 hours of monitoring. And if that was the primary outcome, if you looked at 6, 12, 36 months, much more likely to find it. And by 3 years of monitoring, essentially, 30% of patients with unexplained stroke had AF versus only 3% in the standard of care approach. And in that study, again, not powered to look at stroke as an outcome, but there was evidence that the recurrent stroke or TIA risk was lower in those who had an implanted monitor, presumably because they had an anticoagulant because of the detection of the AF, but the results weren't significant for prevention of stroke. But again, the study wasn't powered for that endpoint. And so at this point in time, we don't have that kind of high-level evidence that would indicate that these patients should all be anticoagulated, or that rather that patients with unexplained stroke should have a cardiac monitor because it will reduce clinical events. We don't know yet if it will reduce clinical events. So between EMBRACE and Crystal AF, we have a comparison between 24 hours of monitoring and 30 days of monitoring, and between 24 hours and 3 years. But we don't have a head-to-head comparison of 30 days or some other duration and the long-term monitoring yet. We don't have proof that, we do know that detection of AF changes management, but we don't have a proof that it reduces risk of stroke yet. The other thing that's interesting, I think, about these results is that, yes, at 3 years, 30% of patients will have atrial fibrillation detected, but that still leaves 70% left. And so the question is, what else might be out there? And recently, there's been a rethinking of the kind of philosophy or idea, hypothesis, behind how atrial fibrillation leads to stroke. First of all, in studies that look at patients who have implanted cardiac monitors that are followed, people who have other cardiac diseases or are followed for a long period of time, pacemakers and things like that, there's no clear temporal relationship between when someone is in atrial fibrillation and when they have their stroke. So in other words, a person very likely will have their atrial fibrillation, not have the stroke, and then sometime later, in fact, 90% of the time, more than a month later, will go on to have their stroke. So there's no tight linking of the time of the AF and the stroke itself, and even very brief episodes of AF are common. In addition, we know that ectopy, apart from atrial fibrillation, premature atrial contractions, even paroxysmal supraventricular tachycardia may be associated with stroke without AF itself. There are genetic mutations that are associated with atrial fibrillation that can be associated with the occurrence of stroke before the person develops their atrial fibrillation. And there's even this phenomenon of electromechanical dissociation such that the heart will actually be on echocardiography, it will have the characteristics, the flow characteristics of atrial fibrillation, even though the surface EKG shows normal sinus rhythm. And so our traditional ways of capturing that atrial fibrillation may not be perfect. And so this has led several of us to think of new ways in which atrial disease may be connected to stroke. And that idea, I think, that many of us learned in medical school, the idea of the fibrillating atrium being like a bag of worms, right? And it's the stasis along the wall of the atrium is what causes the stroke, may not be accurate anymore. There are many other ways in which atrial dysfunction can lead to thromboembolism, including stasis without the fibrillation itself. There may be endothelial dysfunction, myocardial fibrosis, inflammation, thrombophilia, and even dysfunction or abnormalities of the left atrial appendage itself that may cause the stroke. And so according to kind of the traditional model of how risk factors may lead to stroke through atrial fibrillation, the idea would be, sure, you can get strokes from, vascular risk factors, hypertension, and so forth in lots of different ways. But if it sets up an abnormal atrial substrate, that then leads to atrial fibrillation, and that leads to stroke. That would be the traditional idea. But we would hypothesize it could also be the case that that abnormal atrial substrate could lead on to stroke without first going through that atrial fibrillation pathway. And so if we think of atrial fibrillation and stroke, there's a little bit of that iceberg above the water in which that's a pretty clear connection that we all accept as a well-defined cause of stroke. And there's a big chunk of the iceberg that might be occult atrial fibrillation. And then there potentially are a lot of other ways of indicating disease of the atrium listed here that could reflect atrial disease and subsequent risk of stroke. And here's some of the evidence for that. I mentioned PSVT before. My close colleague Homunculus at Weill Cornell did a really nice study several years ago where he looked at the HCUP, the Healthcare Utilization Cost and Utilization Project, data from California, and looked at people who had a history of paroxysmal supraventricular tachycardia, but no atrial fibrillation, and compared them to people who had no PSVT or atrial fibrillation, and found that PSVT itself, without AFib, was associated with twice the risk of stroke. Administrative database has limitations, but supports that idea that other diseases of the atrium could be a problem. One can look at characteristics of the EKG that reflect P wave function. So for example, the P wave in lead V1 reflects contraction of the left atrium, and blowing up here on the left, you can see that the terminal portion of that wave deflects below the horizontal median and has a depth and duration that can be measured. And that is an indication of dysfunction of the left atrium. And we looked at this in our study, right? This is, in a sense, my laboratory. I'm not a basic or lab scientist, so we do our work in the community of Northern Manhattan. And what we did was we follow people. So the study began, as I mentioned, back in the 1990s. People continue to be followed now. Some 30 or so years later. But assessments were done when people were first enrolled back in the 90s, and then we followed them over time for evidence of stroke. And I was able to convince a young woman who had come to Columbia as an undergraduate. She wanted to do a research project for the summer, Madeline Hunter. And Madeline came to us asking about a project. And I said, well, we have these old EKGs stored in a box somewhere that nobody's done anything with. And maybe we could look at those and see if there's anything about this P wave story that might relate to risk of stroke. And these EKGs were the ones that used to be collected on the long paper strips and rolled up in this box. And we took them out and gave them to Madeline. And I felt so bad asking her to do this because I thought this was going to be the biggest waste of her summer. But Madeline very diligently took digital calipers and measured that tiny little P wave on all 1,200 or so EKGs that we had stored that way, and then looked at these individuals' risk of having a stroke over the ensuing 20 years at that time of follow-up that had been done. And what we found was that the P wave terminal force, the product of the depth and duration, was associated with risk of stroke, and particularly cryptogenic or cardioembolic stroke. So strokes that looked embolic, even after adjusting for all the usual risk factors. So tremendous work that Madeline did. She ended up working with us for a few more summers, became a medical student at Columbia, and now I guess I'm proud to say she's a vascular surgery resident at Columbia, although I am disappointed she didn't go into neurology. But at any rate, she's doing great, and we're very proud of her. Serum biomarkers can be used as measures of atrial cardiopathy as well. NT-proBNP, for example, is associated with risk of stroke in the cardiovascular health study, even after adjusting for atrial fibrillation, heart failure, and left ventricular hypertrophy. And cardiologists will tell you also that it's not the left atrium itself that causes strokes, it's the left atrial appendage. That's where 90% or more of the blood clots are found in atrial fibrillation. And the left atrial appendage actually has a bunch of different morphologies, can have different shapes. And in our group, Shadi Yagi, he was a fellow with us at Columbia. He's now on faculty at Brown. He had done and continues to work in this area. And there's evidence, as you can see here, people have given fanciful names to the left atrial appendage, depending on its shape. And some of them, like the cauliflower shape, you could just imagine that's got a lot of nooks and crannies within it that might be a great place for a blood clot to hide out. And in cross-sectional data, primarily, people have found that that's true, that certain morphologies of the left atrial appendage, like cauliflower, cactus, windsock, are more associated with risk of stroke, whereas chicken wing seems to have the lowest risk. So, just knowing somebody has AFib might not be the whole story. It may be helpful to know what the morphology is of left atrial appendage. And similarly, other ways of getting this information about the left atrium could come from cardiac MRI, which can show delayed enhancement in patients with fibrosis. So just different ways of getting this information. So all of these different biomarkers, essentially, of left atrial cardiopathy may be an indication of risk of stroke. So who cares? What are you going to do about it? Well, there's some evidence that we may want to anticoagulate those patients. So there was a trial done many years ago called the WARS trial that was run by J.P. Moore at Columbia, which was done at the time when we all assumed, if a patient had an ischemic stroke, they should be anticoagulated. And so Dr. Moore said, well, but we got to test that. We got to prove it. So he ran the WARS trial comparing aspirin to warfarin for patients who didn't have known AF or carotid stenosis and so forth. And much to everybody's surprise, there was no evidence that warfarin was better than aspirin in that trial. In fact, the probability of an event was slightly higher in the patients who were anticoagulated. And so that kind of helped, among with some other studies, to put a kibosh on the use of anticoagulation for patients with stroke in general. But one great thing was that blood samples were stored from all the patients enrolled in WARS. And we were able to go back many years later and measure NT-proBNP levels. And what we found was that patients who had elevations in NT-proBNP did get a benefit from being on an anticoagulant, whereas those who didn't have those elevations did not. So something about NT-proBNP could be used as a predictor to determine which patients should be anticoagulated. Secondary analysis of clinical trial data doesn't prove anything, but it is hypothesis generating. And of course, that study was done with warfarin, and we have better anticoagulants now. Now we have the direct acting oral anticoagulants, which are just as effective as warfarin, in some cases more effective, and certainly have a lower bleeding risk, particularly intracerebral hemorrhage bleeding risk, than warfarin. And so all of this led me and my colleagues, including Human, who I mentioned, as well as Will Longstreth at the University of Washington and David Tershwell at University of Washington, to design the Arcadia trial that I mentioned at the beginning and David mentioned. And the idea behind the Arcadia trial is essentially to take patients who have unexplained stroke, don't have atrial fibrillation, but have biomarkers of atrial cardiopathy, and randomize them to aspirin or to apixaban, one of the newer anticoagulants, and see whether these patients derive benefit from being anticoagulated in just the same way that we do with patients with atrial fibrillation itself. So the trial is a multi-center randomized blinded trial. It's being run, it's funded by NIH. We do get some industry support in kind from BMS at Pfizer that provide the apixaban free of charge, and some help with the assays from Roche. And our primary outcome is recurrent stroke. And here you can see the inclusion criteria, and you can see the biomarkers that we look for. So patients, they have an unexplained stroke, and then they have to have one of these three biomarkers, either that P wave terminal force on the EKG greater than a certain threshold that is associated with risk of stroke from our observational data, they have an elevated NT-proBNP level, or they have severe left atrial enlargement. They just need one of these three biomarkers, and then they can get into the trial. Any history of AF excludes them, severe cardiomyopathy, or of course, if they have an alternate explanation for their stroke. And in addition to our primary outcome of recurrent stroke, we look at bleeding complications, and we're targeting 1,100 patients. And here you can see where we stand now. We have I think today it's 991 patients randomized. We have 183 sites in the US, and we're also doing an ancillary study looking at cognition as well. And so I like to say that in the future, it's possible that neurologists won't care about atrial fibrillation because we would have biomarkers that can tell us whether patients should be anticoagulated. So we don't need to search for the atrial fibrillation itself. Wouldn't it be nice, right, if at the time of the patient's stroke on day one, we could know whether they should be anticoagulated and not have to wait for the monitoring to tell us that they have AF or not. So perhaps the next stage in the history of AF, or atrial disease and stroke, will be the atrial cardiopathies. Now let me shift. I think I have a few more minutes, if I'm not mistaken. And what I'd like to talk about is the relationship of infection to one of the main causes of stroke, which is atherosclerosis. So, you know, in the old days, we used to think of atherosclerosis as being a lipid deposition disease. But research has shown that atherosclerosis is really a very active, immunologically driven disease. So there's endothelial injury or dysfunction that sets in motion an immune cascade that leads to lipid accumulation, cytokines and growth factors get released, macrophages are activated, and that forms the atherosclerotic plaque. And there are many underlying causes of this, traditionally oxidized LDL, many other things that contribute to it, but infectious agents have also been hypothesized as one of the things that could stimulate that immune cascade that leads to plaque. And this is actually not a new idea. Back in the 1970s, investigators found that in a chicken model, you could induce atherosclerosis with a avian herpes virus. And back in the 90s, around the time that I was a fellow, people were very interested in the idea that certain specific infections, particularly chlamydia pneumoniae, might be a cause of atherosclerosis. It could be found in carotid plaque specimens. It could be found in all of the cell types of the vessel wall, and maybe it was contributing to disease as well. There were a number of serologic studies that showed associations between chlamydia pneumoniae antibody titers and cardiac disease risk, as well as stroke risk. But most of that was using retrospective data. In prospectively collected data, the impact or the effect of serologies against chlamydia pneumoniae and risk of cardiovascular disease was quite small, if at all, and not statistically significant. But I would argue that it's really pretty unlikely that there would be a specific bug that causes atherosclerosis, right? If there were, we probably would have found it a long time ago. And isn't it much more likely that many different agents can contribute to the inflammatory burden in the vessel wall that accumulates over time and may be influenced by other host factors, like how much you respond to an infectious agent, or other environmental factors as well. And so it may not be a single infection, but rather the combination of infections to which somebody is exposed throughout their lifetime that leads to the atherosclerotic burden. And so we did some work on this in the Northern Manhattan study as well. We measured serologies against several different common infections, and we found that if each of these was looked at individually with risk of stroke, adjusting for other risk factors, there was an association, but none of them on their own were significantly associated with risk of stroke. But if we then put them into an index of infectious burden, adding them up together, we found that that combined infectious burden index was associated with risk of stroke, even after adjusting for demographics, risk factors, inflammatory markers like C-reactive protein, and leukocyte count. And similarly, even after taking out those people who had a history of MI, the effects were seen as well. And so this supports this idea that it may not be the individual infection, but rather the combination of infections that increases risk. In our study, these were all stroke-free people. We were able to measure carotid plaque in them and look at the thickness of the plaque. And we found that the same infectious burden index was also associated with plaque thickness as well as with risk of stroke. Mira Katan, a visiting neurologist from Switzerland, showed that the infectious burden index was also associated with cognition using our measures like the mini mental state exam or telephone cognitive evaluation. And we also did MRIs on a subsample of our cohort, and we found that there were associations of measures of procalcitonin, which is kind of a more holistic measure of exposure to infection, with silent brain infarcts and white matter disease in the brain as well. All supporting this idea that an infectious burden, perhaps acting through inflammation, could contribute to risk of not only atherosclerosis, but stroke and brain disease. Now that speaks to whether chronic infections are associated with subsequent risk of stroke and stroke mechanisms like atherosclerosis. But another question is whether an acute infection, like the flu or sepsis or COVID, might be associated with a stroke, in the short term. In this way, the infection would be acting as a trigger of the stroke, not as in the way we usually think of a long-term risk factor over time, like diabetes and so forth. But to answer the question of whether a risk factor may trigger a stroke requires a different type of epidemiology, because in that case, we're not asking the question, why does one individual have a stroke compared with another? In other words, why does a person with hypertension have a stroke compared with a person without hypertension? We want to know why within a given individual who has hypertension for many years, why do they have a stroke on this day rather than another day? And is there something about that that we can learn and potentially prevent the event? And so to do that kind of work, we do a different kind of study. So here you can see some of the list of papers that show this association. But to do this, as an example, we did a study in the cardiovascular health study, large national epidemiologic study that followed about 6,000 people over the age of 65 for many years. And what we did was to imagine somebody having a stroke on a given date, in this case, December 30th, 2004. We could then look at the 90 days before they had a stroke and compare that to the same 90-day calendar period 1 year before and then 2 years before. And instead of looking at an individual as being as a case or a control, we could look at those time windows before the stroke and then 1 year and 2 years before that as a case period of time versus control periods of time, and look at the likelihood that they had an infection in those time windows. So this is called the case crossover design, and we could look at different durations of time window as well. And then look at the risk. And so When we did this, we could see that if we looked at the 90-day window prior to a person's stroke, there was a threefold increase in their risk of having a hospitalization for an infection. If we looked at a 30-day window, it was sevenfold more likely, and 14 days, just 2 weeks prior to their stroke, eightfold increase in likelihood of them having an infection. So this kind of dose response effect, the closer in time you get to the infection, the higher risk, supports the idea that the infection might have some triggering effect on risk of stroke. This is looking backwards in time. We're looking at people who had stroke and looking at the likelihood of infection prior to their stroke. So we also did an analysis in the same cohort, looking in a more traditional way at people over time to see whether if we followed them over time, and then every time they experienced a hospitalization for infection, we could look at the 14, 30, or 90 days after that to see whether there was a stroke that occurred during that time. So it's a prospective design. And we found that that same dose response effect held, an increased risk after somebody was hospitalized with an infection, and it held after adjusting for other risk factors and measures of carotid disease without much change with those covariates included. Again, supporting this idea that stroke may be triggered by infection. And others have found similar results. Liam Smith in the New England Journal published this very nice paper looking at the risk of stroke after outpatient hospitalization visits as well. Amelia Boehm in our group looked at influenza-like illness as a stroke trigger, found the same thing. And interestingly, what she found was that the effect was much greater for younger people than for older people. It may be because older people have many other reasons to have a stroke, but in younger people, a much higher risk of stroke associated with flu. And this kind of association of infection with stroke risk in young people has been seen in other analyses and even in children. So for example, thankfully, stroke is very uncommon in children, but there is a well-known syndrome in which kids get chicken pox, and then subsequently they develop an arteriopathy, often of the middle cerebral artery, that leads to stroke. Again, very, very rare, but it does happen. And so pediatric neurologists who deal with stroke a lot will recognize this syndrome and its association with VZV. But the question is whether there might be other herpes virus infections that might have a similar association. And so together with colleagues Heather Fullerton at UCSF and Gabrielle de Weber at Hospital for Sick Kids in Toronto, we did a study to determine whether in a larger sample, in an epidemiologic way, we could show that infection was associated with stroke in kids, in particular herpes viruses. And so this was a case control study. We had sites around the world, and we had 355 kids with stroke, and then 354 kids who were seen in emergency rooms for a fracture or some other reason, from whom we were able to collect blood samples and get a history of recent infection. And we found that, in fact, based on history from the parents, there was an increase in stroke risk associated with an infection in the prior week after adjusting for other causes of stroke in kids. They don't have a lot of the other risk factors we look for in adults, but we can look at demographics and so forth. And among the kids for whom we did have blood available for serologies, we found that there was a greater likelihood of these kids having a herpes virus positive serology than in the control samples. And it wasn't only VZV, also HSV1 and 2, CMV and EBV were increased in those kids. And interestingly, of those kids who had positive serologies, only about a half of them had a history of infection in the past 4 weeks. So some of these viral infections could have been asymptomatic and yet potentially have led later to the stroke. And even after adjusting for these other factors, there was a twofold increase in risk of stroke in kids associated with a herpes virus infection. And the other thing we were able to do with these samples was to explore whether we could identify other infections that could be associated with stroke. The primary hypothesis of our study was to look at herpes viruses, but working with Ian Lipkin and the group at Columbia who do emerging disease work, we explored 28 different bacterial and viral pathogens, and we found that there was an overrepresentation of positive serologies for parvovirus B19 in kids with stroke, compared to none of the controls and no healthy children from other studies. And so parvovirus B19, it turns out, can infect red blood cells. In kids with sickle cell disease, it can lead to aplastic crisis and hemolytic anemia. And it also infects many other of the cell types that are in the vascular system. Parvovirus B19 causes Fifth's disease, the slap cheek syndrome that small children get, which can be benign, but again, very rarely has been associated with stroke as well. So supporting the idea that infection may be a cause of stroke in some children. And all of this, of course, was brought home to us during the COVID pandemic. And here's just an example of one of the cases we had at Columbia. This was a 37-year-old woman from the Dominican Republic who did have a history of diabetes, hypertension, morbid obesity, as well as complications of pregnancy. And she came in with an acute left hemiplegia. Interestingly, she'd had a history of cough and shortness of breath and a mild fever, but her testing for SARS-CoV-2 was negative. On exam, she had a right hemispheric syndrome, and her head CT showed a blood clot in her right middle cerebral artery. She got IV TPA, and her CT angiogram, shown here where that arrow is, indicated a filling defect in her right carotid artery with some swelling in the retropharyngeal space consistent with some edema. And she had evidence of occlusion of the vessel on that CTA that you see there on the right. You don't see her middle cerebral artery there. And she ended up having no evidence of completed infarct, thanks to getting the vessel opened with thrombectomy. So she had good recanalization. Here you can see her on the left, you can see there's no evidence of completed infarct. There was a lot of hypoperfusion of that territory, and there was an occlusion of her carotid artery on the angiogram that was reversed with thrombectomy, and subsequent PCR testing for SARS-CoV-2 was positive. So she was lucky, had a very good outcome, but I think is a very good example of how, number one, COVID could be associated with stroke, and how this tends to affect particularly people who have other risk factors like hypertension and obesity. There are a number of different mechanisms. We learned during the pandemic a lot about thromboinflammation leading to clots in blood vessels, and data from the Weill Cornell group looking at their patients showed about 1.5% of patients who were positive, or rather patients who had COVID-19, 1.5% of patients with COVID-19 turned out to have stroke. And this was actually higher than the likelihood of having a stroke after influenza. They compared rates of stroke with flu to rates of stroke with COVID and found it was about 7-fold higher for those with COVID than flu. So both infections may be associated with stroke, but the effect of COVID that much greater. And in the Heart Association, we created a registry, our COVID-19 cardiovascular disease registry, at the onset of the pandemic, and similarly found that among about 21,000 patients nationally with COVID in our registry, about 1.4% had stroke, half of which were ischemic strokes, and smaller proportions of other subtypes of stroke as well. And so, although COVID does seem to be associated with risk of stroke, thankfully, the proportion of patients is really on the order of 1 to 2%, and not necessarily much more than that. So what does this mean, that infection may lead to risk of stroke? Well, I would say traditionally in atherosclerotic and cardiovascular disease, we focused on a vulnerable plaque. And then we learned that the patient could have multiple vulnerable plaques at the same time. There was something about the patient as a whole that was affecting their blood vessels more diffusely. And perhaps we can now advance and think about a vulnerable time period as well. The time after infection, perhaps the time after an unhealthy meal or something else that might lead to a period of time when a stroke or other event is more likely to occur. And perhaps we could then focus on that time period as a time to intervene and prevent an event. So if we think about the therapeutic implications of the relationship of infection to stroke, we can certainly use the serologies indicative of infection as a way to identify patients at increased long-term stroke risk due to infectious burden or other markers, and then target them with anti-inflammatory or antibiotic treatment. Certainly, flu and COVID vaccination can be used to prevent stroke. The American Heart Association has recommended since 2005 that people get vaccinated against the flu, not only to prevent flu, but to prevent cardiovascular events, including stroke. And similarly, we can identify people at an increased near-term, short-term stroke risk due to a recent infection and perhaps treat them with medicines like aspirin and statins and so forth as a way to prevent them from having an event. That's a hypothesis, not yet proven, but an idea that we might use. It's being tested, frankly, now, right? When we think of the trials going on for patients with COVID who then get randomized to an anticoagulant versus an antiplatelet agent or placebo, that is a test of this hypothesis. So far, not proven. There was actually just a study that came out in COVID patients that didn't demonstrate a benefit to anticoagulating outpatients with COVID. Another time, perhaps we can talk about anti-infectious or anti-inflammatory strategies to prevent long-term cognitive decline after stroke as well. So as I wrap up, I just want to acknowledge colleagues from Columbia University and the University of Miami, as well as Mount Sinai, for work on the Northern Manhattan study, particularly Ralph Sacco, my longtime mentor, and really, the leader in stroke epidemiology work, as well as the funding from NIH and other funders, Leduc and Diadexis for some of that work. And then people from the cardiovascular health study, like Will Longstreth and colleagues, and my colleagues from the Arcadia trial that I talked about, as well as the funding from NIH, BMS Pfizer for the drug, and Roche as well. So I will stop there. Thank you so much for your attention. And I guess I'd be happy to take questions now. Thank you.
Well, Mitchell, look, thank you so much for your time tonight. Just a beautiful presentation. Really appreciate it. And hopefully we'll bring you back maybe this time next year for an encore to cover a different topic.